definitely these ones are very interesting and important. Okay, so I think it's 5 p.m. So we'll just slowly get started. Just some housekeeping rules. So it's roughly 10 minutes per paper, allowing for some additional time for discussion. And whoever wants to ask a question, then either during the discussion, just unmute yourself and speak up, or write the question in the chat. Then I will basically then pose it on your behalf. So today's journal club is about cardiac MR first pass perfusion, technology and a diagnostic approach that over the last years has matured to being the method of choice for centers that can offer that service. A lot of data have shown its outstanding robustness and also diagnostic performance, but also more and more data on the prognostic performance and with the MR impact trial, also on the impact on outcome, which is always, of course, the ultimate goal, to improve outcome. So the meeting is being recorded, just in case for those who do not want to be recorded, then now it's time to jump off. And otherwise, it's a huge pleasure for me to welcome two authors here to present today. So it's Xenios from Amedeo group at the King's College, and Théo and who published a couple of important papers earlier this year. And we'll kick it off with the first one of those two. And I would like to ask Xenios to share his screen and walk us through the paper, which asks a very important question. What's the best? So quantitative perfusion or quantitative first pass perfusion has made it into the first line of our clinical focus. It's still it still has to be worked out. So it's still important to have papers and reports on how to exactly do it. And this one addresses the important question: where do we sample the blood for the arterial input function that is required for quantitative perfusion imaging, that you have one sample with the low resolution technique to track the bolus, a small bolus, and then from there to calculate the input function for the quantitative part that comes thereafter. So, Xenios, with that having said, take it from here.
Thank you, Matthias, and Bettina as well for the invitation to present this paper. And thank you everyone for being here. So with this study, we really wanted to go back to the basics of perfusion quantification and examine the impact of perhaps one of the most critical aspects of quantification, and that is the arterial input function. As Matthias explained very nicely, this is very important. And I'm just going to show a clip here to explain what this really is. So the IF is a signal captured over time, shown by the orange curve here. And this visualizes the first pass of the contrast agent in the blood pool. And this is required for normalization, in a way, of the myocardial signal sampled in the myocardial tissue in the convolution analysis, and allows us to measure absolute myocardial blood flow in physiological units so that we can actually compare flow across patients. Now, despite that the true input to the myocardium is the coronary arteries, these are quite practically impossible to actually image with standard perfusion sequences, owing to limitations of spatial resolution and associated partial volume effects. So for the last 2 decades, quantification pipelines have been measuring the IF in the basal left ventricular cavity instead, because it's a conveniently large structure and it's imaged in the same short axis slice as the myocardium itself. However, there is actually no evidence to support the use of this or any other specific location for that matter for the IF, and particularly with respect to the diagnostic accuracy they offer in the detection of coronary artery disease. This was exactly the aim of this study. We explored the capability of contemporary dual sequence implementations that decouple the IF slice from the 3 myocardial slices to assess the impact of various IF sample locations on perfusion quantification, and also explore their diagnostic accuracy of the corresponding stress MBF and MPR for the detection of abnormal myocardial perfusion. So what we did is to recruit prospectively 25 patients with suspected or known coronary artery disease, referred to our 3 Tesla Cmr facility for a stress perfusion assessment. And to explain our methodology, I'm just going to move straight to figure 1 here. So following acquisition of standard localizers and cine images, we acquired perfusion images at stress and then at rest following a minimum interval of 10 minutes. And we use for this dedicated dual sequence implementation, as I said, that allows us to select any arbitrary imaging plane for the AF slice. And we chose the 3-chamber view here, as it allows us to compare the standard LV, as well as the LA and the aortic root from which the coronary arteries are originating. And this is as close as we can get to the true input to the myocardium. So both the AF slice and the 3 short axis myocardial slices were motion and coherence sensitivity corrected. And then signal intensity was converted with better concentration based on these T1 values obtained from T1 maps acquired just before each of the perfusion scans. And we then manually extracted the AF curves from the 5 locations in the LV3 levels corresponding to the 3 slices. And we estimated pixel-wise MBF using Fermi deconvolution. And based on manually traced contours of the myocardium, we also estimate these 16-segment bullseye plots for stress and rest MBF. And using this, we also estimate segmental MPR for each patient. I should actually note that you can find all sorts of information about our pipeline, the methods, as well as the additional file we published along with the paper. So moving on to statistical analysis, we had 2 of our cardiologists visually assessing the perfusion images and assigning the segments into normal and abnormal, where abnormal refers to perfusion defect lasting 5 or more dynamics. And this visual assessment was used as the reference classification for performing ROI curve analysis for segmental stress MBF and MPR for each of the 5 AIF sampling locations. We also performed some other analysis, including non-parametric analysis of variance, linear regression, and blunt Abnett analysis. So moving on to the results, the included population was quite standard for suspected or known coronary artery disease, slightly more males than females, median age of 68 years, and I think expected heart rates at rest and stress. And a quarter of myocardial segments were visually classified as abnormal, exactly 100 out of 400 segments. So we compared MBF and MPR separately for normal and abnormal segments, and we found significant differences across the 5 AIF sampling locations, both for rest MBF, stress MBF, and MPR as well. And lots of values reported here, but I've just highlighted the sentence here that shows the range of stress MBF in abnormal segments. And this was from 1.71 milliliters per gram per minute for the aortic root, all the way to 2.41 milliliters per gram per minute for the mid LV cavity, so quite high range. We can also see actually the range in figure 2 here. So it's quite interesting to note that despite the obvious differences in absolute MBF between the 5 AIF sampling locations, MPR was more homogeneous, quite homogeneous. And that was expected because both rest and stress MBF are similarly affected by a change in the AIF sampling location. And just an example, stress MBF for the aortic root was significantly different than stress MBF for the basal LV, but the MPR for these 2 locations was very similar and was not significantly different. So moving on to table 2, I won't focus too much on linear regression and blunt Abnett analysis, but in short, we compared all locations against the clinical reference basal LV just to make sure they're still correlated despite the change in the sampling location. And we found that that is true for all of the locations, but MPR for the apical LV seems to have the lowest correlation overall. And we think that's because of the quite dispersed distribution of measurements we've seen for this location here. So figure 3 shows the plots for the aortic root, which have the best correlation overall and agreement with the basal left ventricle. But now let's move on to the most interesting bit of the study, which is the diagnostic accuracy versus visual assessment. This is shown in figure 4 and table 3. Stress MBF for the aortic root had the highest overall diagnostic accuracy with an area under the curve 0.90, 80% sensitivity, and 85% specificity. And using the DeLong method, we found that this is actually significantly different than stress MBF for the other 4 locations, and also performed better than the MPR for the 3 left ventricular locations. You can actually see, just mentioning, you can actually see the p-values in the supplementary tables here, highlighted in yellow. So it's quite interesting to note in this figure here that the large variability in LV-based stress MBF and MPR that we've seen in the previous figure led to the lower diagnostic accuracy compared to the aortic root. And this is likely multifactorial. For example, flow in the LV is particularly complex due to the turbulent flow. And this could mean several things. It could mean, for example, that some of the gadolinium molecules could pass from the imaging plane more than once, and therefore they are measured across multiple dynamics. It could also mean that we are actually skipping some of the gadolinium molecules by selecting a smaller Y in the basal LV, for example. Now, at the same time, the IF is acquired during systole, but depending on what exactly you place, it's placed on which phase on the systole, the LV signal could be exacerbated, could worsen by the combined effects of partial volume effects, contractility, and trabeculation. Now, on the other hand, the IF curve sampling the aortic root, which are the red ones, do not suffer from such effects, and therefore corresponding flow values are much more reproducible than the other 4 locations. I should also mention that the aortic root is closest to the true coronary arteries, as required by the very first papers published for quantification. And this could assist in the deconvolution analysis because we have essentially a shorter and more reproducible tracer arrival time from the aortic root to myocardium, compared to, for example, for the basal LV, which could vary a lot across patients. I should conclude by going to the last figure of the paper, which is figure 5, and this focuses on the impact on ischemic burden. Here we show stress perfusion maps for the basal LV and the aortic root in a patient with obvious perfusion abnormalities in all segments. And there is a significant difference in stress MBF, as you see, which leads to a vastly different ischemic burden when specific cutoff values are used. We are mentioning the ones we use for this particular example. Specifically for stress MBF, we measured an ischemic burden of 18.75% for the basal LV, which is quite small compared to 93.75 for the aortic root. On the other hand, the ischemic burden based on MPR was identical despite a small difference in one of the segments. But the take-home message, I would say, is not necessarily to rely on MPR more than stress MBF, because stress MBF has a higher diagnostic accuracy, as we've seen, but rather that thresholds of flow are not transferable across different AF sample locations, and that we need to use the location-specific thresholds. And since our study was done on a relatively small population and diagnostic accuracy was measured against visual assessment, we do strongly believe that further validation and measurement of such flow thresholds must be obtained in larger cohort, perhaps, and against the reference methods such as invasive FFR or perfusion. Thank you.
Thank you very much. So this is very interesting, the paper, and there are lots of questions. So everybody who wants to ask a question, just add it to the chat. So when I read that, there were a couple of things that were basically striking. One is the numbers for stress MBF look better than the numbers for the perfusion reserve. So do you think it would be sufficient just to look at the stress?
Well, that's a general question that perhaps I'm not the best to answer, but stress MBF, and you're talking about diagnostic accuracy, aren't you? I assume. So we know from previous studies, probably the conclusions from this paper are not conclusive with this aspect, but we know from previous studies that MPR offers additional complementary information, at least, for the detection of, for example, for cases where we have a globally reduced flow, like myocardial dysfunction. There are actually studies that combined stress MBF and MPR in statistical models and found that it actually increases the diagnostic accuracy for the detection of ischemia compared to stress MBF alone. So I would say if you have the ability to just spend 2 more minutes and acquire a REST scan to estimate MBF, to estimate MPR, I don't see why not doing that. But I don't know how you want to add anything to that.
Yes, absolutely. Thank you, Xenios. I think it's very appealing, the perspective of being able to rely just on the stress images. And I'm talking about the diagnosis of CAD here, not microvascular disease. And that's because we want to have fast protocols and we want to have thresholds of absolute values which are reproducible. And we see more and more that the changes in baseline which are caused by the first injection of gadolinium, which is usually reserved for stress, the effect of this injection on the rest acquisition is a bit difficult to model, and because clearly when we perform the fitting of our curves and particularly the conversion to gadolinium concentration units, we are making some assumptions on what are the baseline T1 and T2 values, and therefore, this variable level of T1 values at baseline of the rest acquisition makes it very difficult to have a reliable estimation of MPR, which ends up depending on parameters like left ventricular function, renal function, and so on. So I really like the idea of using stress images. I'm personally only using stress, or almost exclusively using stress images in my reporting. From the point of view of programming, it's certainly easier to deal with one type of image rather than trying to obtain an NPR map, which is very complex on a pixel-wise, particularly because the heart will be acquired at stress and rest in different phases, so the volumes will not be the same. So in practice, it's very difficult to obtain. The only very limited drawback I see is that from other data we published recently, it would look like in some patients with microvascular disease, some of the abnormalities in myocardial perfusion are not just linked to a reduction in the absolute stress values. There would be a reduction in the MPR due to an increase of the baseline perfusion rate at rest. So there's still a question open whether rest images are useful in these patients to identify and distinguish between structural and functional microvascular abnormalities. But seems to be a problem for a subset of patients.
Okay, thank you. We'll have to move on soon, but we want to go through some additional questions. So one I had, when I look at the numbers, and I agree that the diagnostic accuracy overall was best for the aortic root, but if we look at the sensitivity, it looks like the basal left ventricle and even the apex, which always causes trouble, seem to be better at the cost of a reduced specificity. Now, if your diagnostic approach is mainly looking at a high negative predictive value, so you need a high sensitivity as well, then what would you say? One could argue, okay, then you're maybe better still off with the basal left ventricle. Just a short answer, because we have two more questions from the audience.
Well, the reply is probably not short, I would say.
Yes.
But I mean, statistically speaking, we probably need a bigger sample to properly estimate, like more reliable sensitivity and specificity values. And there's quite a big difference in these two values here, for example. And that is totally a statistical issue. I think, statistically speaking, when you have, if you see, for example, the middle V, if you have a distribution that is not normal, you see the median is actually quite high here. So it pushes your cutoff value quite high, and that's why you are essentially classifying half of the normals as abnormals. So that's why your specificity is quite low. Whereas for the aortic root, it seems to be likely quite homogeneous, had normal distributions, and that's why you get very similar sensitivity and specificity values. There's a very nice cutoff in the middle of that. Yeah. So perhaps there is an effect that we don't know yet. Regulation problem, the middle is more significant, but yeah, we probably need more patients to.
Then you could, of course, also play with a cutoff on that end, just for the aortic root, if you want to tweak sensitivity. Okay, so very briefly, because we're already a little bit going over time here, a question from Mohammed Rabbani: are there cases of decreased MPR without visually seeing ischemia? Just a quick answer. It's not directly related to the paper, but given your experience, do you see that visually it's not apparent, but when you do the MPR, you say, okay, there seems to be something?
Yes, maybe I can take this question. I think it really depends on the spatial resolution of your scans. The ischemia is characterized by reduced perfusion, but mainly subendocardial reduced perfusion. And therefore, if there is a real abnormality, you should see a gradient of perfusion across the wall with a relatively preserved epicardial perfusion. If you see low values everywhere, I would consider as a first option the fact that perhaps in that patient, the stress was not as effective as expected, and would exclude some technical issues at that level. That would be my first step.
Okay, yeah. Oh, thank you. And then a question from João Cavalcante. Do you think the results would be also similar or applicable to other patients we also scan with LV dysfunction or aortic stenosis, stuff like that? So patients who could have microvascular dysfunction due to other reasons?
I don't see why not. I would expect to see a similar significant difference in any sort of patients, to be honest.
Yeah. Okay. Thank you very much. That was really interesting. So we'll move on to the next paper titled Prognostic Value of Stress Cardiovascular MR in Asymptomatic Patients with Known Coronary Artery Disease, and will be presented by Théo from the Institut Cardiovasculaire Paris Sud, and currently also at Johns Hopkins. So Théo, thank you for joining, and take it from here.
Thank you so much, Matthias. Do you hear me? Yeah, it works?
Yes, very well.
Wonderful. Thank you so much for this opportunity. We are really happy to share this French work assessing the prognostic value of stress CMR in a dedicated population of asymptomatic patients, but with known CAD. In terms of the background, as you know, the recurrence of cardiovascular events remains a huge cause of mortality and morbidity in patients with known CAD. This is really important to insist on the fact that in patients with non-CAD, with or without symptoms, the mean prevalence of inducible ischemia using stress CMR is estimated around 20%. Recently, some very interesting studies emphasize the fact that asymptomatic patients with this inducible ischemia have at least similar risk of adverse cardiovascular events, MI or cardiovascular death, as symptomatic patients with typical angina. So this is a question about the silent ischemia, and some studies show that it's a very important risk markers of recurrence. However, as you know, the European or American guidelines do not recommend systematic stress tests using CMR, echo, or nuclear imaging in the follow-up of patients with known CAD without symptoms. As you know, there are several large stress CMR prognostic studies, including some asymptomatic patients. However, there is no study dedicated to this population with a specific analysis. Therefore, in pink just here, this is the aim of our study, to assess the long-term prognostic value of stress CMR, so this silent ischemia in asymptomatic patients with non-CAD, and to assess, as you will see, the incremental prognostic value above traditional risk factors. Let's go for the methods. During 2 years, this is a monocentric study, we recruited all consecutive asymptomatic patients with non-CAD referred for stress vasodilators CMR. This is important to insist on the definition of non-obstructive CAD. So 3 possibilities. First, history of PCI, history of CABG, or non-MI. So very classic. In terms of outcome, after a follow-up, we assessed as primary endpoint, a composite endpoint, the combined major adverse cardiovascular events defined very classically in these prognostic studies as cardiovascular death or non-fatal MI. Regarding the CMR protocol, maybe some discussion here. We worked only at 1.5 Tesla. Maybe a discussion on this point with Jérôme Garot in Paris, and on our center, we used only dipyridamole for cost reason, but we discussed about that. Regarding the stress perfusion imaging, our analysis was only visual, so no quantitative analysis here. But, and I think it's a choice, an important choice by Jérôme, we used systematically 6 slices, 4 short axis views, a 2-chamber view, and a 4-chamber view. Of course, as you can imagine, we lose a little bit a temporal resolution, but it's really important for us to check systematically in both long and short axis views any defect perfusion. But please, if you have some discussion about this point, it could be a pleasure for me to discuss. Regarding the Cmr Image Analysis, as you know, it's really important to check the definition of the ischemia. 4 points. This is a subendocardial or transmural perfusion defect. First, in at least 1 myocardial segment. Second, persisted for at least 3 phases by on-peak contrast enhancement. As you know, this is important to difference a true perfusion defect to the dark rim artifact. 3, with a consistent coronary distribution. And 4, probably the most important point, it's really important to check that there is no colocalization with a late gadolinium enhancement, because as you know, if in the same area you have the perfusion defect in the first pass sequence and the late gadolinium enhancement, this is an infarct, and this is not an inducible ischemia. This is important to emphasize this point. Just here, as you know, the presence of ischemia is interesting, but the extent of ischemia is important. And exactly as in the SPIN study, for example, very classic, we used 3 categories with mild, moderate, or severe myocardial ischemia, defined by an involvement of 1 or 2 segments for mild, 3 to 5 segments for moderate, or at least 6 segments for severe. Regarding the statistical analysis, again, very classic, using a time event analysis, a Cox proportional hazard method. I will show you the results, but it's important to insist on these 4 models. It was a demand of the reviewers of GCMR, just for the information. A model 1 using a stepwise selection. A model 3, the discussion with GCMR reviewers. A model including traditional cardiovascular risk factors, age, male, BMI, hypertension, diabetes, smoking, dyslipidemia, and left ventricular ejection fraction. And as you can see, in the model 2, we had the presence of ischemia or the LGE to the model 1, and in the model 4, exactly the same, but to the model 3 at the beginning. It's really important to assess the incremental prognostic value of stress CMR parameters to check if there is an improvement between the model 1 and the model 2, and after the model 3 and the model 4. But I will show you that just after. To assess this incremental prognostic value, it's really important to know that there is 3 classic tools for the C-index to assess the discrimination, 2, the net reclassification improvement to assess the reclassification, and, sorry, the IDI to assess also the discrimination. Let's go for the results. This is a table 1. So our final population was constituted by 1,342 patients, including almost 30% of patients with ischemia. As you can see, patients with ischemia were older, with a higher cardiovascular risk, pretty logical, and frequently with a higher rate of prior PCI or MI. This is because it's so nice to see some pictures. This is 4 patients from our cohorts. And as you can see, 2 important sequences. In this way, this is the first pass perfusion sequence. And in this part on your right, the LG sequence. The first patient's normal. The second patient, as you can see here, a really important transmural defect in anterior wall, but no LG. This is inducible ischemia. The patients see there is a defect of perfusion, but as you can see, a perfect colocalization with the LG. So it's just an infarct without new ischemia. And the patient D, this is not very frequent, but so interesting, with both an infarct and a new ischemia. In this figure 2, really simple, but I think it's so clear this importance of both ischemia and LG. This is the annualized rates of MACE in the group without ischemia or LG. This is pretty low, 2.4 years. And in patients with both ischemia and LG, this is the highest for almost 50%. This is a univariable analysis, but we can go immediately to the Kaplan-Meier curves. So on the top, this is the cumulative incidence of MACE, and it's so important to assess also the cardiovascular mortality on the bottom. And as you can see, the presence of inducible ischemia was associated with an odds ratio more than 2 of the risk of MACE. When we discussed about prognostic, it's so important to assess subgroup analysis to see if this prognostic power is consistent in all subgroups. And as you can see, regardless of the LVEF value, for example, or if you have an hypertension or not, with or without diabetes, as you can see, the presence of ischemia was systematically associated with MACE. In multivariable analysis, I will go very quickly. As you remember, the model 1 using the selection using stepwise. If you had myocardial ischemia or LG, it was systematically associated with MACE and cardiovascular mortality, so independently associated. And if you use not a stepwise selection, maybe less clinical relevant, but immediately all traditional risk factors, this is the same results for the presence of myocardial ischemia, also independently associated with MACE. And other point, when we discussed about prognostic, it's so important to assess the age interaction. And as you can see, I will just show you the top one. If we check by different group, subgroup of different age, systematically in red, patients with ischemia present a higher risk of annual event rates, of MACE, compared to patients without ischemia. Last point, if we check just here in the incremental prognostic value, it's really important to emphasize the fact that both ischemia and LG, just here, improve the C statistic of 0.07, the NRI and the EDI compared to the traditional risk factors model. In terms of discussion, so the main results of our study was in asymptomatic patients with known CAD, referred for stress CMR. Both ischemia and LG were independently associated with MACE and severe mortality, with this incremental prognostic value above traditional risk factors. I think it's an important message. And just to conclude, as you know, this is more cardiologic than radiologic, but I think it's so important. Recent studies have shown really promising new therapy strategies targeting inflammation or coagulation to decrease the risk of recurrent cardiovascular events like CONTOS study, COMPASS study. So there are a lot of possibilities in these patients with non-CAD. So maybe we can imagine that the stress CMR could help us to stratify the risk of these patients to maybe target the good patients for these new therapies. Thank you for your attention.
Thank you very much, Théo. It's great to have prognostic data. And so the questions I have, there are just two, and you both mentioned them already. Most published studies and I think also majority of centers is used to adenosine, but I know that especially in the States, dipyridamole, due to basically a little bit of simpler handling, is preferred. So what is your personal take on the one being used as the other? Dipyridamole is an adenosine agonist, so it's not much different in terms of what it does, but where do you see the major differences?
Thank you for this question. With Jérôme, we use dipyridamole for 2 points. First, the cost, because it's cheaper, and this is a real reality. And for another point, just one access on the arm, it's enough. Also for adenosine, as you know, we need to have one access for perfusion to the adenosine and for the gadolinium. So we worked a lot on the workflow with Jérôme, because he performed 20 to 25 CMR per day on the CMR, and he worked a lot on this workflow to optimize maximum. Another question possible is the perfusion at rest. And we did never the perfusion at rest for the same logical. But as you can see with this paper, it seems that in terms of prognostic value, it seems pretty consistent with previous prognostic CMR studies.
Yeah, no, thank you. So this is certainly, there are also some data saying that the dipyridamole may not be as favorable as adenosine with regards to safety, because the longer acting pharmacokinetics. So that's also something to consider. And with the 2 IV access, I know that in Berlin, we for a while used still 1 IV access, even for adenosine, but of course, then about 5% or maybe 10% of our patients had an AV block, transient AV block during the injection, because you basically get a bolus of the adenosine. So it's certainly only for basically for the tough guys among us to do that on a regular basis. The other question that they also mentioned is using every other image instead of each image. My concern always was, and we also did that for a while, is the temporal resolution enough to catch really the difference and the number of data points? Is that enough to see the first pass really? So what was your feeling here?
Again, this is a monocentric experience, and it's not the true, of course, and I think the discussion is important. We test sometimes different variation of this protocol with Jérôme, and we feel that the temporal resolution is enough to check defect perfusion due to a subepicardial stenosis. This is so important to emphasize the fact that we never see microvascular disease. This is, I think, really important. And to compare to the prior discussion, I think it's really different to the quantitative perfusion CMR. And in this case, we want to see a defect perfusion due to subendocardial coronary stenosis. And in this case, our feeling is this is enough. And to be honest, when you have both long and short axis views, it's so comfortable when you have a doubt or if there is an artifact to say, okay, this is it. This is a true defect perfusion.
Yeah, I have to agree that having long axis views gives a lot of additional confidence. And also long axis views have the advantage that you actually personalize, cover more myocardium. So that's why I also want to make a case here also for the long axis views in perfusion that is really helpful. Exactly. Okay, thank you very much. In the interest of time, we have just one more question. So, but it's a question from Judy Liu that takes us into the clinical realm. And as you briefly mentioned at the end of your presentation, this is, of course, a wide topic. We have data from the past saying, okay, and the European guidelines reflect that, okay, leave those asymptomatic patients alone, just don't do anything, but there may be new therapeutic options. So her question is, in the light of the results of the ischemia trials where the revascularization did not improve outcomes, and we have similar data from other studies before, what do we clinically about it? But I think you already kind of addressed that to some extent by possibly new therapeutic options, right?
I try to respond very quickly. Of course, ischemia trial is in our head. I agree with you. I think there is not just revascularization, but new therapy too. But to address this question about ischemia trial, I think ischemia trial respond to the interests of the coronary vascularization guided by stress echo, nuclear imaging a lot, but very cried by stress CMR. And sorry if I'm enthusiastic about stress CMR, but I want to see.
Sorry for that.
But I want to see a new ischemia trial with only stress CMR. And I think maybe the results could be different. Some recent studies showed the importance of the extent of the ischemia assessed by stress CMR. And maybe we can imagine one day have this study, and probably coronary vascularization could be helpful in some patients.
Yeah, no, I think I agree. While I'm also not a very aggressive cardiologist with respect to especially invasive procedures, we still have to learn, because some of these patients may actually really benefit from more than just the primary or secondary prevention that we offer them. So I think you're making very good points. Because it's already so late, I will have to close the shop. However, please stay on there, Théo, because there are questions from João Cavalcante, a couple of questions. Please answer them in the chat. I'll leave it open, but I want to otherwise thank you both, Xenios and Amedeo, and also Théo for the wonderful presentations. Before I stop next week, so July 14, at the same time, there will be the JCMR Journal Club, and Dr. Antonella Meloni will present the paper Myocardial Iron Overload by CMR, native segmental T1 mapping. So it will be interesting. I got the big competitor to T2 Star is T1 here, and the editor of that edition of the Journal Club will be Raymond Kwong. So with that, I want to thank everybody for joining, and maybe you can just answer the question, Théo, for those who want to stay on. Just the questions that you can see in the chat from João, and we'll stay on for that time. I will also stay on. So
thank you so much. So for this question, I will read it. First, how was asymptomatic status verified, self-reported? This is an excellent question. It was assessed by the cardiologist, because we are only cardiologists. There is no radiologist on our center for cardiovascular imaging. At the beginning of the CMR exam, this is systematically, there is a quick interview. What was for the two concatenation? Absolutely, this is exactly the case, but I think you understand that with the discussion just before. But absolutely, there is a decreasing of temporal resolution, of course, but as we discussed, with a better global coverage of the LV. Question 2: what was done to the information CMR? Did management change outcomes? This is the big question, the decision making of the coronary revascularization and treatments. We didn't measure that very carefully, so it's not possible to use that for the paper, but we can just say that it's a clinical routine in our center. So we give the presence of the ischemia, the presence of late gadolinium enhancement, and the viability and the extent of the ischemia. And of course, in our center, the extent of the ischemia is taken account to the decision making. But as you imagine, there is a lot of elements, the LV function, and to be honest, we didn't collect that prospectively. So my response is just, it's our clinical routine. And 3, how did you treat peri-infarct ischemia? This is a really important question. We mentioned that in the methods section. To say that there is a peri-infarct ischemia, we want to have at least one segment more than the LG in the first pass sequence as defect perfusion. This is not perfect because, as you imagine, Joao, it's so difficult to define this peri-infarct ischemia. But we use this definition with at least one segment to try to be more specific than sensitive on this point. That's it.
Sorry, on that note, what we did for the, when I was involved in the design of the CMR part for the ischemia trial, what we did, we used the concept of subsegments. So having a subendocardial, subepicardial segment and treat them as separate entities, which allowed for an ischemia in the subendocardial portion, but not in the subepicardial, but also, for example, an infarct in the subendocardial, with ischemia in the subendocardial, which is technically in the same segment, but still outside of the infarct. So I'm wondering whether we should not use the better spatial resolution that we have in MR as opposed to nuclear to also provide more granular information here. So that is right. I think an aspect to consider. Yeah, and then the other one, as you pointed out, that is a good point, the potential confounding effects of the clinical decision made after the CMR, because doctors who take care of that patient, knowing, hey, there's LGE and perfusion deficit, they may be more likely then to refer this patient, which then counts as a clinical event. So that is definitely important to consider here.
Yeah, absolutely.
Okay. Great point and great discussion. Thanks, Joao, for the great questions.
Thank you so much, Joao.
Okay, so if there is not something else, then thank you again, Théo and Amedeo and Xenios.